Well, good evening to all of you, and I'd like to start by thanking the chairman and the organizers for bringing me all the way to Bombay. I haven't been to India for, I think, at least 5 years. It's been a long time, and I'm glad the whole COVID nightmare is over so that we can travel again. My job today is to talk about pharmacological management of obesity, but I would like to thank the two previous speakers for setting the stage, because I will be taking a lot of the information that they have provided to actually provide a rationale for why it is that we have to seriously consider obesity not just as a chronic disease, but also have to consider this to be a condition that is going to require probably lifelong medical treatment for most patients. Here are my financial disclosures. I'd like to thank the company Novo for bringing me all the way to India for this event. Now, one of the things that I think we have learned is that there is a tremendous accuracy in the way that the body regulates body weight. And what this essentially means is that despite the fact that we have large fluctuations in our energy intake and our energy expenditure, and all of that, if you look at people over the life course, on average, there's actually quite a small increase in body weight over time. And if you want to do the mathematical calculation on this, the average caloric intake per year for most adults is somewhere in the range between 700,000 and 1 million calories a year. If you end up, by the end of the year, gaining maybe half a kilo, and you convert, and let's say most of that is fat, that's only about 3,000 excess calories. Which means that despite all the fluctuations that you have in your energy intake, somehow your body is managing to regulate your body, your energy requirements extremely accurately. In fact, there's less than a 0.5% deviation in this, despite of all of these changes. Now, the organizers, they wanted to use this technology, and so they asked me to put this question to the audience into my talk. I hope you've already taken the Slido, the QR code here. And I want to ask you these questions. Which one do you think varies most from day to day? Is it, when you look at people over time, is it the energy expenditure? Is it energy intake? Both? Neither? And the most important question, does it even matter? So I'm going to give you a second or two to answer the question. All right, we should have your response coming up over here. There you can see. Both, of course, is the correct question. Okay, we're still seeing the results. I'm not going to comment it while you're still voting. Let's see where this ends up. Okay, all right. So of course, there's a lot of variation in energy intake. There's a lot of energy. There's a lot of variation in physical activity and energy expenditure. But at the end of the day, the right answer perhaps is, or the clinically relevant answer perhaps is, that it doesn't really matter. Can we go back to the slides? Because what we've learned is that despite of all of this up and down, I mean, you can go on a fast and not eat for 2 or 3 or 4 days. You can have a significant bout of exercise because you go on a holiday and you decide that during your holiday you want to go for 10-kilometer walks every day. At the end of the day, it doesn't matter. Because the homeostatic system for energy homeostasis, and that's why we call it a homeostatic system, actually does its job. And it doesn't only do its job, it does its job astonishingly well. And so it really doesn't matter. This whole system is designed, and that's why you have a homeostatic system, like we have in the body for all kinds of things, because it shouldn't matter. You can go through bouts of excessive expenditure, whether it's an illness, you can go through famines, you can go through fasting, you can do whatever you want. At the end of the day, the job of the homeostatic system is to make sure that your energy balance is sustained. Now, if I were to talk about fluid balance, all of you, of course, the body maintains fluid balance. And when you go to medical school, we spend a lot of time learning about fluid balance. And in fact, I'm a nephrologist, so I don't really just learn about fluid balance, I teach fluid balance. And there are whole textbooks on fluid balance. What most of us did not learn in medical school was energy balance, how complicated this is, and how important it is. And that brings us to the actual problem that we have because of the way that our body regulates fluid balance. What this literally means is that all of our short-term approaches to obesity management, where we try to change energy balance, ultimately are not successful for the vast majority of people. There are always exceptions to this. When you look at every single randomized control trial that has been done in the field of obesity, and this is just a selection, and it doesn't matter what you do. You can do formula diets, you can do intermittent fasting, you can do ketogenic, you do whatever diet you want. You can do them with psychological support, without psychological support. You can do them with exercise, you can get personal trainers, you can do resistance training versus aerobic exercise. It doesn't matter. What you can see is that in every single one of these studies, people lose weight, because losing weight is not the problem. The problem we have in conservative obesity management so far has always been the fact that when you look at the same populations, irrespective of how you induce the weight loss, whether it was quick, whether it was slow, whether it was protein supplements, no protein supplements, high fat, high carb, low carb, doesn't matter. At the end of the day, 2 years later, 3 years later, if your patient is still 3 kilos below where they started, you have done successful evidence-based lifestyle management. In clinical practice, this means if I have a patient who I see who has 100 kilos, and I work with this patient and the patient does everything I tell the patient, and after 3 years they are now 97 kilos, I have done successful conservative obesity management. I should congratulate my patient and I should congratulate myself, because we have reproduced exactly what the science tells us. And here's the story. If I was able to take conservative lifestyle management and somehow manage to pack it into a tablet or an injection, and I go to the licensing authorities and say, I want you to license this medication, which is diet and exercise, as a pill for the treatment of obesity, there is not one single licensing agency, from the FDA, the EMA, the health authority, not a single health authority would ever approve this pill for the treatment of obesity, because it does not meet the 5% sustained weight loss over 2 years that is a requirement for licensing a medication for obesity. I would never be able to get this through any regulatory authority. Why is that? The single reason for this is, and thank you, thank you, Shashank, for taking us through the physiology. We've already learned about this. See, what is the role of the homeostatic system for energy? Why has this evolved? And why is it so powerful? It has only one job, and that is to defend us against energy deficits. That is the job of the system. It has not evolved to protect us from too much calories. It has evolved to protect us from times and occasions where there are too few calories. That's why we are here. Sickness, famines, wars, migrations, whatever you want. The reason we are here is because we have been able to make it through those times. And so the job of the system is to defend us against weight loss. That is its job. And it does it very powerfully. And again, I don't have to take you through all of this because Shashank did a beautiful job of taking us through this. But the adaptive response to any kind of energy deficit is that this homeostatic system jumps in and does the exact opposite of what you're trying to do. You are trying to lose weight. The homeostatic system is trying to maintain weight. And so the minute you try to lose weight, you're actually fighting your biology. You're fighting your homeostatic system, which is working against you. And again, it's a complex system, and it does this job very effectively. Now, Shashank is taking us through the details of these different parts, and I use this slide a lot. If you think of food intake, appetite, eating behavior, as Shashank told us, there are three different, you can think of this as three different parts of the brain doing different jobs. The most powerful part of the brain is the homeostatic system. This system is fundamental to protecting you against weight loss. When you don't eat, you get hungry. When you eat, you get full, you stop eating. That's the homeostatic system. That is your hypothalamic system. Lots of different hormone signals and whatnot involved. Complex system. But this job of this system is to protect you against weight loss. That's the job of the system. Then we have that second part, the hedonic system. See, the homeostatic system cares about your body weight. The hedonic system does not care about your body weight. It cares about other things. It cares about pleasure. It's a different part of the brain. It does other things. Now, one of the tricks of the homeostatic system is if I activate the homeostatic system, it will drive hedonic eating. If I lose enough weight, even the foods I don't like will suddenly become attractive. So the homeostatic system can activate the hedonic system. But remember, the hedonic system has nothing to do with energy regulation. Okay? You can also see that the signals that are dopamine, serotonin, opioid, cannabinoid receptors, it's a very different system. It's a system that is also relevant for addiction medicine. If you talk to our colleagues who work in addiction medicine, and you can see some of the medications that are being used, bupropion, naltrexone, those type of medications which are starting to be used there. But it's a very difficult system to tackle. Hedonic system, it's a very powerful system. And then we have the executive function system. That is the weakest link. Now think about our treatments. What have been our conservative treatments? On which of these three systems have they focused? When you take your patient, you educate them, you send them to the dietitian, you try to motivate the patient, you give the patient, an app, you tell them to count their calories, you tell them to weigh themselves regularly, you tell them to, eat slowly, do all those things. Which of these systems are you targeting with that treatment? If you call that lifestyle treatment, it's the behavioral intervention. That is the weakest part of the system. If I want to go after the hedonic system, things are already going to get more complicated. Now it is not enough to motivate the patient, to educate the patient. That is not going to do anything for the hedonic system. Now you have to start using techniques that you're going to be using for people who have other addictions, etc. Things get more complicated. So now I'm talking about psychological interventions, maybe a few medications that our colleagues who do addiction medicine use. Much more difficult to control the hedonic system. But here's the thing. No amount of lifestyle education, no amount of motivation, no amount of teaching people about calories and protein intake and all that stuff, no amount of psychological intervention is going to change the biology of the homeostatic system. There is only one way to change the biology of the homeostatic system. You need an intervention that changes the biology. The surgeons have been doing this forever. Because one thing we have learned about surgery is that when you have a sleeve, or you have a gastric bypass, or you have a BPT, or they keep changing their operations, but whatever the operation is, it works because it changes the underlying biology. You're actually changing, the communication between the gut and the brain, and that changes the biology of the homeostatic system. So the surgeons have been doing this for a long time. Now we are entering the era where we are starting to understand that is where we need to target our obesity treatments, because we know the lifestyle stuff, if you get 3 kilos after 10 years, after 5 years, you have done great. Psychology, it's a nightmare. We don't have the manpower to do psychological counseling, which probably then has to be lifelong for everybody. It's not even going to be possible. We are now realizing this is a biological disease which we have to target. We have to change the biology of the homeostatic system. The surgeons have been doing this. This is why surgery works. Now we are entering the era where we can start mimicking some of those mechanisms that the surgeons have been doing without knowing what they were doing. Right? This was by accident, more or less. We can now start mimicking some of that with the upcoming drugs or medications. So what's the situation in India? In India, I understand you have 2 agents that have been approved. We have the good old Orlistat, which everybody knows, which I say if you don't like your patient, then you give them Orlistat. Some people call it Oilistat. It is also very good for when you put patients on a medication that causes constipation, you can add some oily stat. It works great. Patients don't like it. This has been around forever. It's not very effective because ultimately it does not change the biology. Right? You're not targeting the hypothalamus with this. You're targeting the gut. So it has very limited efficacy, which is explained by its mode of action. Now, as we move into the GLP-1s, we are starting to do what the surgeons have been doing. And that was almost by accident. There's an argument, was it by accident? Some people now, they claim, no, we already knew that and we started the development very early. But I think it was more of an accident that they discovered that this medication, we use the term medication, but we shouldn't actually call it a medication. It's a hormone. We're using a hormone here. It's hormone therapy when you use a GLP-1 agonist. And there we have now discovered that it's actually pretty powerful, surprisingly powerful, especially as we go to the more and more long-acting molecules here. So semaglutide, as you know, is a GLP-1 analog, which has a long time of action. And what we have realized is that when you start treating patients with these medications, and I'm sure all of you have experienced this, patients are now telling you when they get on these medication or they get on this medication, they tell you exactly the same story that you have been hearing from your bariatric surgical patients. Doctor, I'm less hungry. I'm happy with small portions. I can go for 3 or 4 hours without even thinking about food. Never happened before in my life. I feel that I'm in control of my eating because I know I have the power to say no. I can go to a buffet and I know I'm not going to overeat. We've been hearing this from our surgical patients all along. And now you're getting the exact same thing the patients on semaglutide are telling you. Doctor, thank you so much. I feel now I am in control. I'm no longer afraid of being confronted with food because I know I can make the right decision. And sometimes that becomes a problem because, I don't know if you've actually heard this, so I've had husbands complaining because I started their wives on semaglutide because the husband is now saying, my wife has lost complete interest in food. She's no longer cooking the meals. I send her grocery shopping. She comes back, she doesn't bring any foods. We want to go for a nice family dinner. Wife says, no, that's fine, you guys go. So it is actually damaging my life. So my quality of life has gone down. My wife's quality of life has maybe gone up, but my quality of life is bad. The first time I actually heard this, I was hearing this from a surgical patient, that the husband of a surgical lady was complaining that his wife was no longer doing this. I heard now the exact same story from patients on semaglutide. So we know that what we are achieving with these medications is very similar in its biology to what the surgeons have been doing. So now that we have semaglutide, of course, the companies are super excited about this. And they have huge development plans, right? And, you have the injected semaglutide. We've had this now for a while now. We've introduced the oral semaglutide, which I know is available here. Now they're still working on, maybe introducing the injectable semaglutide, and you're also looking at a higher dose of the oral semaglutide. Now, the story with the oral semaglutide and the injectable semaglutide is that at the end of the day, when you look at the doses, you use 2.4 milligrams when you inject it. I need 15 milligrams when I, take the tablet. That's because the bioavailability is low. But if you use the right dose, you can get the exact same exposure relationship, which means that we can take a look at all of the studies that have been done with injectable semaglutide and expect that the biological response is probably the same when you use the oral semaglutide. You just have to dose it appropriately. And a lot has been done in this. The STEP program has been perhaps one of the most comprehensive programs. We joke about this. So, so if you look at the STEP program, I think there's now 10, there's probably 12 or 15 studies now going on. So when are you going to do step 25? You just keep going because it's been extremely well studied in all kinds of populations. They've done osteoarthritis, they've been doing HFpEF, they've been doing all kinds of stuff. And of course we have Asian studies going on in South Korea and Japan, Chinese populations, etc. So there's a lot of data. I mean, we have so much data now on semaglutide, on how it works and what it does. And what it does, and that's what the buzz is about, if you saw The Economist last week, actually this week, it talks about these wonder drugs. Again, I don't call them drugs, I call them hormones. And you're looking at 16, 17, 18% weight loss on average. And Shashank remembers when we were going around talking about the big advantages of 5% weight loss. Nobody talks about 5% weight loss. Forget 5% weight loss. Now we're talking 10%, 15%. We're getting closer and closer to what the surgeons are actually used to seeing. So consistently, of course, people with diabetes, they get somewhat less weight loss, but we've known that for every treatment that exists. Look at the categorical weight loss. If somebody would have told me, even 5 years ago, that we will have a medication, a once weekly injection, or now you take the oral form, where, look at the septic, where I can get 20% weight loss in 40% of patients. I would say that's crazy. We're never going to see that. We are happy with 5 and 6%. Here we're looking at 20% weight loss. That is surgical territory. That's what the surgeons are used to seeing. In medical treatments, we have never seen that sustained over 2 years. I don't know any lifestyle study that has ever been able to, forget about, lifestyle studies can achieve 15% weight loss, but I've not seen a lifestyle study, randomized controlled, where you've actually maintained 15 kilos weight loss. If you can sustain 5 kilos, you're doing very well. And of course, we see everything that you expect to see when you lose weight, whether it's an improvement in glucose metabolism, whether it's CV risk factors, whether it is NASH, whether it's HFpEF. The studies are ongoing, but I can already tell you that I would be extremely surprised if we don't see those benefits with these medications. We have a reduction in waist circumference. Shashank mentioned the importance of ectopic fat. I totally agree. That is the real target. That's the real culprit. You look at what happens with blood pressure, diastolic, systolic, C-reactive protein, triglycerides, all the stuff that we know is going to happen and is going to be good, and the surgeons have already been doing this, is what we see with these medications. Change in glycemic category, you start with people who have impaired glucose tolerance, it gets better. There are studies now that look at people with impaired fasting glucose, you prevent the development of diabetes. Every single thing that you would want to see happen and that you would predict happens has been seen in clinical trials. And I can tell you that there's more clinical trials going on. So the big question you always have, of course, what's the safety profile? Now, here's the thing about the safety profile. And I can tell you personally that I was very surprised. I'm still surprised, actually, that the safety profile is closely related to the mode of action. And that there has not been a single signal in the safety profile that could not be explained by the mode of action of these medications. So there has not been some unexpected surprise that there is some organ, some part of the body where things are happening that we would not have predicted. Because what are the patients telling us? They feel full. Yes, they get some nausea. Yes, if the nausea is, is strong, they may get some vomiting. We do change, GI motility. But these are all transient things. These happen early on, and we have all the studies showing that the nausea you get and the vomiting you get in any of these GI, they don't predict outcomes in weight. So the people say, oh yeah, people are losing weight because now they're nauseous all the time. No. Actually, the people with nausea sometimes are the non-responders in terms of weight loss. Now people say, oh, this is a new compound, we don't know how safe it is. I say, well, what do you know? You don't know how safe it is. We've had GLP-1 analogs now in the market for diabetes, 15 years? Look at all of the studies we have. We've got this leader study, we have the SUSTAIN trials, we have got a bunch of, how much more evidence do you want? Yeah, but we still don't know what will happen in 20 years. Yeah, but we also don't know that for our diabetes patients. Okay? So this whole argument, yeah, we are concerned about safety. No, forget it. We know about safety. Okay? All the other stories that we heard about, it's all manageable. Semaglutide is the start of what I think is going to be a very interesting journey over the next few years. I'm sure you guys have all already heard about tirzepatide. That is going to be sort of the next product. It's an interesting molecule because it targets both the GLP-1 receptor and GIP. And is surprisingly even more effective than semaglutide. If you thought semaglutide, you're hitting 17, 18%, that's pretty good. These guys are hitting 22%, 23%. In fact, when you look at the categorical weight loss with tirzepatide, there's a new category. On the sema slide, I showed you the more than 20% weight loss was a category. On the tirzepatide slides, when you go to the paper, there's another category. It's the more than 25% weight loss. But that is also not the end of the story. Because now we are starting to see even more combinations. CagriSema, which targets both amylin and GLP-1, is probably the next in line. So far, we only have the phase 2 data, phase 1 data, but it is looking extremely promising. So if you look at the weight loss, you're getting 15% weight loss there in a very short time, and if you look at the curves, they are nowhere near plateau, and we are now expecting in the phase 3 studies, which are now well underway, that we might end up with 25, 26, 27% weight loss. That is clearly bariatric surgical territory, which is why the surgeons are so excited about this, because now their question is they can use it as staging, they can use it as rescue therapy, and they can use it on top of bariatric surgery. And now for the first time, we are starting to think, is BMI normalization an achievable target for treatment? We've never had that discussion because it was never possible. If I take a patient with BMI 40 and I get 5% weight loss, they're nowhere close to what you would consider normal. Now that I can titrate weight loss based on the medication, we can actually start thinking about what is the treatment target, and what is the target and what is the treatment dose that we are going to need. The pipelines are full. Everybody's going nuts about this, right? I mean, we are going to see, over the next 10 years, we are going to see almost every couple of months there's going to be a new product. It's an extremely exciting line. So to summarize, the reason that our lifestyle, which is very well meant and it's important, and I'm not saying forget it and don't do it, but what I say is lifestyle management of obesity is as effective and as important as lifestyle management of diabetes. Yes, you will always find the occasional patient with diabetes where all they need is lifestyle management and somehow they change their life and they get remission and they live happily ever after. Sometimes I meet those people and I can tell you those people they're very strenuous people because they are so focused on their lifestyle that it's very hard to be around those people. But they exist and I congratulate them and I'm happy for them. But if I told you, you need to manage your type 2 diabetic patient, you have no metformin, you have no glucose, nothing. All you have is diet and exercise for type 2 diabetes. What proportion of patients do you think you will have controlled? 5%? Maybe? That is where we are in obesity with lifestyle management. 5% of our patients with obesity lifestyle management will work. That's good. Congratulate them. They may not even need us. They will go for a personal trainer. They will learn something. They will read a bestseller and they will manage it. But for the vast majority of patients, we are going to have to start thinking about this being a disease that is going to require medication. Now, I appreciate the question that was asked, well, how long can we keep people on it? And how long should people be taking it? That is a question of access. These are expensive medications because they are new medications. We have to learn how to use them. But if I told you that you can get this medication, that if I can give you semaglutide for the cost of metformin, what would be your argument to stop it in your patient and tell your patient, no, you should start on this for 4, 5, 6 months, lose some weight, and then you're on your own? You would never do that. So what we should be focusing on is the issue around market access. And the question is not how long should the patient wait. See, my answer to the question, because I get this question from my patient, so Dr. Sharma, this works great. How long do I have to stay on this? My answer is till you decide you want to put the weight back on. Thank you.